Well, hello, everybody. I'd like to welcome you today to Scleroderma. My name is John Mahalski. I'll be your moderator, along with Michael Bessert and Bruce Cohen, who is the chapter executive director of the New York chapter. And our special guest today is Elaine Furst, who will be giving us a presentation on family, caregiving, and mobiles. And right now, I'd like to ask Michael to give a little introduction to our guest host today.
Welcome to the Scleroderma Foundation Michigan Chapter's web-based 2020 educational series. This webinar is being offered as part of our strategic planning efforts to move toward web-based learning experiences for the next 3 years to reach more patients, caregivers, and family members who seek to obtain accurate information about scleroderma. There are individuals from all over the world that will access this webinar, emphasizing that we can be connected and sit in front of our own computers, obtaining accurate educational information while staying in our homes and offices. This program is made possible in part by an unrestricted educational grant from Actelion and Boehringer Ingelheim. We thank them for their generous support to the scleroderma communities. This webinar will focus on how scleroderma affects the family. You can locate information about additional webinars on the national website. Today we have with us as presenter Elaine Furst. Elaine Furst is a registered nurse and a nurse educated with advanced degrees in liberal arts and nursing administration. Elaine has taught in 4 university schools of nursing, worked as a staff and head nurse at Johns Hopkins Hospital in Baltimore, and administered a psychiatric hospital and program for mentally ill teenagers in Cedar Rapids, Iowa. Elaine has volunteered with the Scleroderma Foundation since 1994. She is a past chair of the National Board of the Scleroderma Foundation and past president of the Evergreen chapter. Learning from people with scleroderma and making use of her teaching and nursing background, she has given many workshops and lectures on how scleroderma affects people, both patients and their loved ones, and has led support groups from people affected by scleroderma. Finally, since moving to Los Angeles from Seattle in 2002, Elaine works as an extra in TV commercials and movies and TV, sometimes portraying a nurse. The Scleroderma Foundation welcomes Elaine Furst to our educational webinar series and thanks her for her contribution she makes in the scleroderma community. With that said, Elaine, it's all yours.
Thank you very much, John and Michael. I appreciate it. I appreciate your help doing this webinar. And hi, Bruce. This was from your and Laura's invitation, and I'm really thrilled to be able to do this. So, one of the areas that has not been as studied as the disease itself or the patients with the disease is the family of people who are living with scleroderma and other autoimmune diseases. But it's being rectified over time, and people have been studying quality of life, quality of caregiving, and what happens to the caregivers during and before and after they are caregivers. So today, next slide, please. We're going to be covering what a family is, because people have different definitions. We're going to talk about the principles of family behavior, which also includes principles of human behavior. We're going to talk about why the family is important to a patient with a chronic illness, with evidence-based information that we finally have. And we're going to talk about the effects of chronic illness on the family. I'm sorry about that. Which of course is the heart of this video today. Next slide, please. Well, the principles of human behavior are pretty simple. All behavior has a reason. People do things for a reason. And primarily what they want to do is to reduce psychological pain. They want to retain their sense of self and self-respect. And they want to stay comfortable physically and emotionally. So all behavior can fall into the reasons for all behavior can fall into one of those three or all three of those things. And that's why people act the way they do. If you look at the little man in there, you've got personal beliefs, you've got personal behaviors, and you've got personal benefits. And people weigh what they're going to do depending on what they perceive to be the benefits to themselves. Next slide. This is the light bulb principle. How many psychiatrists does it take to change a light bulb, do you think? Well, basically one. It only takes one psychiatrist, but the light bulb has to want to change. Those of you with children know that it's really difficult to make people change. You can't make them change. You need to lead them to change. So I'm saying this because when a family is in crisis or when a family needs to make big changes to themselves as a group, it does take time and patience and working together.
What, Dr. Elaine, what does, once a family, a patient hears the horrible news, basically, that they have scleroderma, what things can we offer to the family and to the patient to, part of that change is acceptance, understanding that life has now been altered. What are some of the things that we can do to really help that family of ours?
Let's hold on to that very fine question, which is the heart of what I'm about to talk about. And we will get back to it at probably slide 11, 12.
Okay, no problem.
Is that all right with you?
No, that's fine.
Okay, bring it up again then.
Will do.
Next slide. Once upon a time, the family was not seen in this way as a mobile. Once upon a time, it was the sick one who got all the family's energy. And gradually, people discovered that families are like mobiles. If you push one part of a mobile, all the mobile is affected. So if you push a fish, push the yellow fish on the bottom of that picture, all the fishes are going to be moving. So family is like a mobile, and whether or not a person says that they're affected, they are. And one of the prime things that happens if you don't talk about it is that the behavior comes out in other ways. So we'll go over that just a little bit more. But keep the mobile in mind because it's a very good model for what happens to a family with anything. The family is affected, all of the family is affected, not just one fish.
That's the first time I ever heard that analysis, but it's very good. It's an excellent one.
Yeah. I do believe that Virginia Satir in the 50s came up with that. She was a wonderful group therapist and focused on the family and realized a lot of things that hadn't been thought of before. So we're going to credit Virginia.
Okay.
Next slide. So what is meant by the words family or family member? Generally, a family is seen as two or more people who are related in any way, biologically, legally, or emotionally. And the patients and family can define their own families, which can include neighbors and friends. And probably you know about this as you've been growing. There are people who are part of your family and are considered to be your family, whether or not you're related by blood. So you need to look at the family maybe in a wider way, because these family members that you've created over time can be a source of wonderful love and care for the family itself, for the patient. I'm so sorry about this.
Oh, that's quite all right.
So the family can be looked at in a lot of ways, and the people that you consider to be a family are great sources of love and caring for all of you. Next one. Now, family support is critical because they're there, because they're affected by what happens to the patient. And the people who study families, sociologists, primarily therapists, psychologists, they look at what happens when a person has effective family support. And this is the stuff that goes on. They follow their self-care regimen better. They have the physical, emotional, and spiritual support to live better with a chronic disease, which isn't going to go away. It waxes and it wanes. It goes into remission, hopefully, and it comes back. They experience less stress than people without support. All of this makes so much sense. They're healthier in general, probably because they're following their own self-care regimen. And they describe themselves as happier than those without support. So you see, they have done some studies on the successful family.
Elaine, I don't know whether you're going to cover this one later, but you talk about effective family support. How do you tell the family? How do you break it to the individuals? Is it a one-on-one? Is it better to bring it together as multiples together so they can hear it and they can all ask the same questions, and so you can answer them so they all hear the same message? They might have different filters, but at least you're giving the same message.
Well, what do you think works? You've been through it.
Well, like I said, my late wife is basically, the thing we found out that when you have the news that you have to share is that it's better to, we found out it was better to have them, all the family together. So they heard it, they all heard the same message. And then obviously, as I mentioned, everyone has their own filters on once they receive information. But I think at that point in time, that's the way it worked for us the best.
Well, see, that is the trick. It worked for your family that way. It is a good logical way to do it because everybody hears the same thing, even if they do have filters. But they can refer back to what was said. It's always good, it's always effective to have written as well as verbal explanations. And then these things have to be repeated. So it's good to also have families come to support group meetings, especially the educational ones. But every family is different. So sometimes families don't want to listen. They don't want to come to a meeting. They don't want to hear about it. There are quite a few ways that people act. Remember, we go back to that other slide, that people act to preserve their self-image and to reduce psychological pain. And sometimes folks just have to ignore it for a period of time until it settles and until they can see what's being done and they join in. So every family is different. The most effective, efficient way of doing it is all together. Possibly the patient and the significant other needs to hear it first, and then bring in others to the doctor's appointment or to the nurse appointment or whatever they find is most helpful, or whoever they find is most helpful. So there are always options for this. Support groups are really helpful, but sometimes it is difficult to get people to come. So it's all out there, it's all available. It's just getting folks to go.
Okay, thank you.
Yep. They have studied social support related to diabetes, blood pressure, cardiac events, etc. And as you can see on the bottom from the article, social support is associated with better health for those chronic diseases as well. Next slide.
I'll make a comment to follow up on Mike's comment and Elaine, what you just spoke about.
Yeah.
You know, the illnesses that you had there on the slide, the health manifestations. You know, scleroderma can be a little bit more convoluted because as you're sharing it with family, and I'll use a circle of different layers of family, which would incorporate maybe social circles and friends. You know, they don't know much about scleroderma, so it makes one of our challenges as a family supporting a patient a little bit more complex that way. And just for people's understanding, I was a caregiver for quite a while, and now working for the chapter and being involved, you know, I'm involved with people. So I see that they're trying to, you know, explain what they have. If you come home and say that you have breast cancer, most of your family kind of understands what it is. If you come home and say you have scleroderma, it's a challenge.
Sure. And it's complicated because it's not one disease either. It's got a bunch of systems that all interact with one another, and you have different problems with different people too. So yeah, but education is the key for all of this. The problem, as I said, comes when folks don't want to show up, you know. And every year at the conference, I meet somebody who says to me, how am I going to get my daughter, my mother, my husband to come to support groups, or to be educated, or to read the materials that I bring home? How do I do that? And that is a challenge, and it takes a lot of finesse and a lot of knowledge of what that other person really means to you and what you mean to him or her to get through that barrier sometimes.
There's some people that you can explain it to death, and they just choose, or as I call it, self-ignorance. And you've explained it to them, and you know, I've had this. I was diagnosed in 2013, probably had it for 2 years prior to that, so I've been dealing with this for 7 years. There's people I'm not going to explain it anymore, you know, and they just act like they don't want to learn. So it's like it's their self-imposed ignorance, and they choose to be that way. I mean, I've provided it to them in writing and all that. So, you know, I mean, it's their choice. So, yeah.
Well, you know, I being a psych nurse, I sort of want to put a different word in there instead of self-ignorance, self-defense. They're defending against something.
Right.
And, you know, if this is a very close relative, then it may be worth the effort to break through that as much as possible. Or if it's somebody who is not so close to you, then give up.
Yep.
You know,
Yep.
you don't have the energy
Yep.
to take care of everybody.
Exactly.
Right? However, if we go to the next slide.
There we go.
One of the things that we're looking at is the concerns of the patient and the concerns of the significant other, whoever that may be. And they coexist. Sometimes they're the same, and sometimes they're not the same. Possibility of death is always number one. The changes in the face and the body is very concerning to patients. And I don't believe these are in a rank order, but we'll get to a rank order bunch of concerns in a minute. So changes in face and body, the reduction or stabilization of pain and disability, it does overlap with the concerns of the SO. There are financial concerns because it's an expensive disease, because it is complicated, and it does require often more than one specialist. And people can't work anymore. Sometimes it isn't as difficult to go to work, but there may be times when you can't work full time and you have to pull back. So there are financial concerns about that. Being independent as possible is always a concern for people who have been active and get a disease that puts them on a couch. And they are fatigued, can't get up, can't do what they're used to doing. And I have met so many scleroderma patients who are bodybuilders and work outdoors and are very, very active. And suddenly they can't. They're not active anymore, and they don't like it. They are very annoyed with this. So they want to stay as independent as possible. It's very difficult to do with the pain and the fatigue. Also, along with that, they want to maintain their roles and status in the family and with daily life. And that's very difficult to do. And they're concerned about other family members. How am I going to break this to the children? How am I going to explain to the kids when they're very little that mommy or daddy are just not able to play anymore or can't take them to school for the time being? The SO also has financial concerns. Maybe the SO has to pull back in order to, from work, in order to take care of the loved one. And that we don't have paid leave in this country for that kind of thing yet. Hopefully we will someday. How do I help my loved one to reduce pain and disability? Where are my resources for that? I'm feeling pretty helpless because I don't know how to do that. How can I take over the family roles that my loved one had and do as good a job as well as maintaining my own family role? I am going to fight for this patient. I'm going to advocate with the doctor and the government and ordinary activities if I have the strength to do so. I have met knights in shining armor riding white horses ever since I joined the Scleroderma Foundation. And many of them are volunteers, and they fight for their loved one with all kinds of strength. And it is a joy to see, but it takes a lot out of you as well. Next.
Let me just add one other thing. I guess one of the things on the concerns of the patient, and I think, Bruce, you probably could testify, is that the patient or the person not to be defined by the disease was always one of the major things my wife had. Was she still wanted, like you said, her independence, but it was not to be the definition of who she was.
Yeah. There's a saying, I have scleroderma, but scleroderma doesn't have me.
Right.
Correct.
So that's what we say.
And you brought up the financial concern, having just done my taxes and figured out what my out-of-pocket costs were. And I figured it out. It cost me $54.95 per day.
Yeah.
For my scleroderma treatment. So that's not per month, like the commercials to protect the animals and the children at Shriners, but mine is per day. And I'm a lucky one because there's a lot of people that are a lot worse. So, but yes,
Yeah.
a lot of
True.
Yep.
That's a good, I'm going to use that. I'm going to put that in there. Yeah. And I'll bet you there are studies also. I know the Arthritis Foundation has for a long time had numbers like that on what it costs to have scleroderma, to have arthritis. Mm-hmm. And I'll bet you we have it somewhere too. And if we don't, we ought to get it.
And like everything else, it rises every day, every day.
Yeah, of course, cost of living.
Yep.
So this slide discusses a research study that was done. They were, I believe this is the one that was done in England as well as America. And you can see in descending order of frequency, the things that a family member of a person with a disease has. The very first one that a caregiver is concerned about in this study is the emotional impact of the disease on the family. The next one is the daily activities. The third is family relationships, and I'm going to get into them a little bit more. Sleep and health was the fourth one. You notice how it goes from 90s down to the 60s. So the first two are very, very important, and then it reduces from there. And the social life is close to the end, but I think it depends on what your population is, because if you have a mean age of 56, it's possible that social life is more important for someone who's younger than that, maybe just married or maybe in 30s and 40s. So it depends on your population. But this is a bunch of stuff that they asked people, and this was the graph that came out of it. Next slide. So to get down to it, these are the things that they were discussing with the emotional impact. And these things might be handled over time. They're probably the most acute at the beginning. Can I have that last slide again? Yeah. Okay. Mean duration of the patient's disease was 8.9 years. So not 20, not 30. Next slide. So it looks to me as though, it seems to me that at the beginning, these things would be very much more important, but they are important throughout. People have difficulty sharing depression and other negative feelings with the patient or with anybody else. They have a lot of stress, loneliness, and helplessness because we focus on the patient, do we not? We're focusing on the patient's survival and not necessarily on the caregiver's mental health or whether or not they are in need of some information or some hugs or some attention. Worry, frustration, anger, and guilt, it gets better when the patient gets better. When the patient is going through a flare, they rise again. The daily activities, they describe missing their own activities. Can't go to the gym because that's the most in the morning, because that's the busiest time for my mother, my wife, my sister. And so I just can't do it then. I have to switch when I go to the gym, or I have to give up going to the gym altogether while she's really sick.
I guess I'll go back to your emotional support. One of the things that, like you said, guilt is a major thing that as caregivers is that as a significant other is that you feel that you don't want to take away the, how can you say, the focus on the patient. You don't want it to, because as you said, you're angry, you're upset, but you're not upset with the patient, but you're just angry that something has happened. And so that's tough.
Yes, it is. And those things can be overwhelming. Generally, since this disease, sorry about that, Mike, but this disease still is a 75% women's disease, that men also sometimes have a much more difficult time expressing any of this stuff. And that is not healthy. So I'm thinking about how we don't have, very often, we don't have caregivers support groups. Some chapters do, but I think every chapter ought to have one, if at all possible, because this stuff is very toxic if you keep it inside. Family relationships. Partners and spouses struggle with the changes in their own roles in the family. How can I still be an effective husband? How can I still be an effective mom while I have this overwhelming caregiver stuff that I have to do, especially at the beginning when you haven't settled into it, when you haven't got all of your resources in a row. Worries that they were neglecting other family members, which probably they were when things were really at their most acute. 24% reported increased family arguments and tension, as well as decreased sex life. And that is partially because we don't talk about any of that stuff. We don't talk about the worry that we're neglecting our other family members. We don't talk about our feelings of depression and helplessness, et cetera, because we don't want to burden other people. The family's already burdened enough. How can I burden my family members with my own problems? And the decreased sex life is a symptom of the tension and the struggles that are going on. Next slide. Sleep loss is difficult. People were mentioning in this study that they had to wake up several times in the middle of the night to help the patient go to the bathroom, or with other kinds of difficulties that they were going through. Sleep loss from having to check the patient during the night. And they describe a decline in their own health, including depression, which always makes health feel worse. A difficulty in arranging holidays. When can we go? How can we go? How can we afford it? How can we have some fun when things are so bad? And sometimes those are the things that you should do when things are so bad, is to take a rest, to take a vacation from the disease if possible.
If I may just comment on the holidays, that's very interesting because my wife and I would be the bad cop. In other words, is that when she did her best to always put the best foot forward when we would visit family and friends, and I would be the one who would set the limits in which she would allow me to, because as well as we all know is that after a scleroderma patient has very active day or two, is that they normally need a down day to be able to recoup. Yep. And so from that standpoint, if you want to look at it, I was the one that she allowed me to be the one to, put the limits on how much we would do, knowing that. So when I would say it would be time to go, people would look at me and would say, hey, Mom, or so-and-so, Elaine is having so much fun. But she knew it was time to go, and then she always left on a good foot, and I was the one who was the bad cop, but she understood and appreciated that.
No, well, that's a good thing. I'm glad she did, because it's difficult to do that.
I'll add to that. Excuse me, Elaine, I'll add to that. Depending on the patient's, and you talked about the study, there was 8.9 years of an illness and the general thing. The patient does learn. My wife learned what her
limits
and what were. So that's good. Other people around you, whether it's family or friends at a holiday or some other kind of event, maybe they didn't totally understand, but you need to save your energy for what you believe is more important. you know, and then you as the spouse, caregiver, and family members need to kind of support that, was what kind of Mike saying. But yeah, I had the same situation in the beginning. My wife would have to, you know, she tried to do too much and whatever. I want to make one other general comment. And I have scleroderma friends from New York, New Jersey, Connecticut, where our chapter is located, but I've been involved for quite a long time around the country. You know, different patients, and this relates to my wife and probably to Mike's life and Laura, John's wife and situation. You know, you have ups and downs. Elaine, you called it flare-ups, you know, but there are patients that can go through life with scleroderma for 20, 30 years that I know that have very limited involvement, you know, but then something happens and it's the unknown. You know, you don't know. It's easier a month later when you had a medical crisis, realizing what happened, but the unknown of going through it is huge.
Oh, absolutely. And it hits you from out of the blue and you don't know that it's coming, which is why it's so important to have those annual tests, because the test will tell you whether or not things are getting worse and whether or not they're staying the same or even getting better, but they will give you and the physician the information to catch things early. So people don't like to go and get their PFTs because they're afraid of the bad news, right? So, but it's very important to go and get those tests every year on time when you're supposed to. It's like a mammogram for us women. If you go and are real good about it, then you can catch whatever might happen, especially as we get older. So it gets very difficult. But you know, after a while, you become an expert in autoimmune ups and downs. And you know, like Mike knows, like John knows, that if a person does too much, that they're going to have a down day. And that's just the structure of your life. And people choose to do too much. And that's something that they want to do because it gets them to feel like, you know, they're still viable and they're still doing what they're supposed to do in life and what they planned on doing. And if they're willing to have the down day and really have a down day, that's fine. It's what they have to pay for what they were doing. The involvement in medical care and support given to the family members was 61%. Unfortunately, caregivers very often are very lonesome because they don't get the support from friends and other family members. People don't understand what it takes to be a caregiver. And they also described lack of information from medical people. I don't know where they were, but basically I think that our rheumatology community is much better at this than a lot of different specialties. Wish they had support groups to share info with. I don't know. Bruce, does your group have a support group for caregivers?
We've had a couple of caregiver events, and you know, our challenge and Michigan's chapter, Chicago and California, is the people are so spread out, you know, to try to get them to come to that. We had the tri-state area had a training program for support group leaders on the role of caregivers and what have you, kind of mimicking what we're doing here. So they had education so that they could reach out to caregivers, whether it was at a standard support group or whether it was a one-on-one situation.
Yeah, I think the standard support groups are really good because they are local, right? I mean, we have 13 of them now. So we spread out across Southern California and part of Northern. And each support group, if they had a support group for caregivers, then that would cover it. So we'll see. But this research does point out that the caregivers in this study felt like they had a lot of need for a support group to share info with. And on the other hand, nobody reported asking for or receiving support from medical professionals. So these folks weren't asking for it, but they wanted it. And we need probably to teach them how to ask for some help or reach out the hand, because we know it's there. We know the need is there for them. Comments?
No, I agree with you. The one thing is I did participate as a caregiver about 4 years ago now, with the University of Toronto, and they were doing a rather in-depth study on caregivers and symptoms. And there is, the paper has been published, and I do have a copy of it. And I am talking with Laura Dias right now about trying to generate, as you say, a support group and trying to use the information. And your presentation is something very helpful that I think we can pivot off of and use accordingly.
Okay, great. Can you send me the reference?
Yes, I will. I will send you the information with the contacts from University of Toronto. No problem.
Cool. They have a very active group up there in Canada that talk about being spread out.
Yeah.
They do some good work.
Yes, like I said, they were doing the research during 2016 and 17, because they were at the New Orleans conference at that year for that in conducting interviews.
Nice.
I am very blessed because I'll be celebrating my 39th anniversary this fall.
Oh, congratulations.
I think what has helped in mine, and I remember seeing this, that I think the divorce rate in the United States is around 50% or maybe higher, but I read somewhere that it's 75% in people with chronic autoimmune diseases. But my wife is also a 17-year cancer survivor. So we went through her breast cancer 17 years ago. So I was a caregiver for her for that year. So I guess it's like a payback in a way, but that it's, you have, we've been there for each other. And that is so critical, because I am an advocate and a peer mentor advocate. And a gentleman that just was diagnosed, I just started working with last month, that his wife left him. And I see that so often, they just can't deal with it. And I mean, the last thing you're dealing with is your own health crisis, and then the people in your life choose to abandon you too. That's pretty tough. Tough. So I'm very lucky, very lucky.
Well, no, my mother used to say, no, Elaine, you're not lucky. You work at it.
True, exactly. True.
So you guys have found a way to have the relationship and keep it going.
Yes.
And that's, pin a medal.
Yes.
Next one. So the takeaways from this study are very clear. Family members have many of the same worries as the patient. Family members don't receive the same attention, support, or compassion as the patient does, unless they're kids. Children get a lot of compassion and support and all that kind of stuff, because people figure that they don't have the skills to deal with tragedy and sadness and sickness and this kind of stuff. So the kids, people are always asking, how are your little ones handling this? They don't ask, how are you handling it, very often. Family members are described in this study as a hidden patient group. Ones who have the potential for becoming actual patients with their own diseases and high blood pressure and obesity and diabetes, et cetera, et cetera. They don't take care of themselves as well as they take care of the other. So that's a set of takeaways from this study. I bet you there are lots more. Next. And here they are. Emotional impact was the most often mentioned effect of the chronic illness. Family members feel they have to hide their own feelings because they don't want to burden their loved one with their feelings. How can we ask her to take care of me when I'm supposed to be taking care of her. Depression, most common psychological result of chronic illness, and that's because of loss. We tend to get depressed when we lose something. We lose our self-esteem, we lose a body part, we lose our face. We don't look the same in the mirror anymore. That's one of the reasons a lot of older people get depressed because they don't look like they used to. Financial security, social life, changes in all of those, and loss of friends. People you thought were friends, they don't step up anymore. They don't want to be around you anymore. They don't know how to handle it. People have grief, anger, anxiety, and sadness over this. And caregivers are not always equipped to play the new role. This is like an advertisement for going to see a counselor. It's an advertisement for that. It's a good counselor will, I don't know if you guys have experienced this, but a good counselor is somebody that can help you put the pieces together again and point you in directions where you can gain back some of your skills that you thought you had lost. So very often I hear that people are referred for counseling after they've been diagnosed because it's so new. And besides the physical aspect of it, there's a lot of loss involved and a lot of not knowing what to do next because it's such a new thing. So I don't know about you guys, but we're compiling a list of therapists, hopefully who are specialists in chronic illness, the psychological results of chronic illness. And we're trying to get a whole bunch of people there so that we can make a list and hand it out to folks who need counseling.
That's a great point. That's something I'll follow up with Laura Dice, our executive director, as I know she has compiled a list of all the doctors for the illness itself, for the cardiologist, the rheumatologist, the pulmonologist, for the patients. But I don't know whether or not we have anything for the counselors or psychologists for people to talk with. But that's a great point. I will follow up with that.
And
The other thing is, it's just like having a PFT that is going downhill. The earlier you pick this stuff up and treat it, the better. So
Sure.
If you know that somebody is struggling psychologically, got to treat that too. I mean, why leave that at the doorstep?
The beginning of the year, I sent an open letter to Laura, the executive Michigan director, and also the National Foundation addressing what I call the white elephant in the room. We have all these wonderful webinars and we deal with Scleroderma 101, but I had said we never discussed the mental aspect of this. The reason I brought this up is, as I said, I was diagnosed in 2013. I was having horrible gastric issues earlier on in the last year, and I see my gastroenterologist every 6 months. And she finally said to me at the beginning of last year, and she said, the medication we have you on should be taking care of your gastric issues. She said, I think you have PTSD.
Mm-hmm.
And I have not served in the military. I just fought it. I said, you're crazy. I mean, no pun. It did not make any sense to me. I was referred to my general practitioner doctor, which then I was referred to a counselor. And yes, I was diagnosed with what is called illness-induced PTSD.
Yep.
There were factors that contributed to it. I'm not going to go into it, but your point of saying a good counselor. And that's another thing, not only is our health insurance and health system in somewhat of a shambles, but in Michigan, the mental health or the counseling system is in horrid shambles. And it's a shame because, like I said, we need support groups more to address the depression, anxiety. And I think I think I read something, it's almost 65% of people with a chronic illness will be diagnosed with illness-induced PTSD. And
It makes sense to me.
once my wife and I just kind of sat back and looked at it, it made perfect sense.
Yeah.
It made absolute perfect sense. And, you know, I've had to change my lifestyle because of that, but it's just, you know, I was having like panic attacks where I've never had them. Just things changed, but it was from my diagnosis, loss of friends, how I was diagnosed, the loss of my job, and it was just, I let too much just slide off my back and I wasn't dealing with it. And then there you go, because you addressed that earlier. So yes, that's a very, very important part of, is what I call the mental wellness of scleroderma patients, is we need that addressed very much so anymore. So.
Well, I don't know about your support group education days, but maybe it's because it's California. But at least once a year, generally twice, there are support group meetings that are pretty much deal with depression, grief, and illness. And I've given many of them, and other people are invited to speak also. So at least once or twice a year, we have something to do with the emotional response of people to illness like this. And so maybe you guys need to start looking around and grab some folks from Mayo or the University of Michigan or whatever and have them in and develop them. You know, maybe they don't know that you guys are out there, and not always are they looking for patients, but
Right. Well, that's, like I said, it was kind of the white elephant in the room, and the way I described it, like at the national conferences, you're sitting at a round table with scleroderma patients of 8 or 10 people. We can sit there and discuss during dinner our horrible gastric and bowel habits, like it's nothing. But we can't discuss the mental aspect. I mean,
Sure.
and it's like nobody wants to admit it. And that's where my, you know, as an advocate, I'm really pushing that now, because number one, it affects me, but in my peer mentoring, I'm seeing it all the time.
yeah.
And,
Well, yeah, we have to redefine it.
yes.
You know, it's not mental illness. It's a
No.
response to events
Yeah.
that we're not prepared for.
Yeah.
I mean, that's what it is. It's grief,
Yeah.
and it's scared, being anxious that we can't handle whatever it is, and because we don't know
Right.
what to do. So, but that's just me. What can I tell you?
Well,
I think it's important.
yeah, we'll work on it, Michael, and we'll see what we can do in the Michigan chapter.
Great. Thank you.
Okay.
I'll add this, excuse me, Elaine. I'll add this, that with our support groups, and obviously we have a large geographical and population territory, so we have like about 14 of them. They all are doing some program speaker in the
Good.
course of the year that deals with other than the medical aspects of the patient, you know, the social, you know, emotional aspect, you know. We've even had ones where it talked about, you know, planning your future from a legal standpoint, a financial standpoint, you know, using a quote, you know, getting your proper paperwork in order, and all of us should be doing stuff like that. But what we've also seen, we're fortunate to have a number of scleroderma, you know, research and treatment centers, and they have added to the treatment groups the social workers. We've had social workers speak at an Ed Forum last year. We had social workers involved with our support groups. So it's better today, Mike, than it was 5 years ago.
Yes.
Good.
Yes.
Oh.
Well, and just not to dwell on this, I'm just the gentleman that I spoke to, 44-year-old man from Lansing, Michigan, just south of us, and he was just diagnosed in January. He had apparently reached out through the National Foundation. They immediately alerted Laura. She got on the pipe, sent me things. She was right up your alley. So what it was, and I explained to my wife, is this guy, his wife left him. He had to give up his job. This is all before his diagnosis, and he was finally diagnosed, but now he's losing his friends, and he's broke. And just that first conversation I had with him, like I said, I don't have experience in this except for my own experience. I'm not trained in anything, but just the text I got from the next day, because just the validation of his thoughts, what he was going through, that he wasn't alone. And just giving him a hope and validation that he wasn't alone, just tremendously turned him right around to, he started texting me, he says, man, you just made my day. So that's why I do this, because if I can help somebody and not dwell on the negatives, but just to give somebody some validation that they're not alone. Yep. And there's help and there's resources is tremendous and lifting them out of the depression and anxiety. So.
Yeah. And it's like magic.
Yes, it is. It is. Just to hear it in their voice that, you feel all alone. That the day of your diagnosis is the day your world stops and it changes.
Yep, definitely changes. Okay, so there's your mobile. And so what can the caregiver do? Face the feelings. Call them what they are. Depression, sadness, anxious, worried, etc. Take care of yourself. That's always number one, actually, in the list of caregiver tips. Exercise, eat right, take care of your own illnesses if you have them. Call on your resources to stay with your patient, loved one, and go off and take care of yourself. Treat your depression with therapy, exercise, antidepressants if necessary, and that goes for the patient as well. Antidepressants can do two things. One, it gives you a little more energy, and that little kick of energy can give you a different outlook. And two, it also handles pain, physical pain. So there are patients who have physical pain who are on antidepressants for the pain, not necessarily because they're depressed. So antidepressants can be very helpful, and you don't have to take them for the rest of your life. You have to take them to get over this hump, because very often it's a hump. If you've got a person who is pretty well put together before the illness, they're going to be pretty well put together after the illness has hit them, if they can marshal all the resources that they used before. So antidepressants is a help for that. Use your social network and, if possible, expand it. That's another reason to have support group for caregivers, is that it expands their support group and their social network. Find a support group with other caregivers, preferably with scleroderma, but the hospitals around might have caregiver support groups or caregiver meetings or education days or whatever, and that can be a support for people. Next. What can the patient do? Because I give, there is a relationship there, and it's complex, and it's made more complex by this elephant that's been delivered. Be aware of your own feelings, including the good ones. Take care of yourself as much as possible. Work with the healthcare team. Get help when you need it. Get emotional help through support groups. Your faith, your true friends, talk therapy, antidepressants, couples therapy. I have to add that, because couples therapy can be very, very helpful. For example, the patient says, I don't need your help, and struggles. And so what do you say? What do you do as a caregiver at that point? But then maybe help means something different to her than it does to you. And so working out, just asking that question, the counselor can just ask that question. So what does help mean to you? And then what does help mean to you? And you can come to an agreement on what it is. or you can see the differences and work it out that way. So couples therapy is a very helpful thing, as well as individual. And I know that that can get pricey, but not all patients need psychiatrists. There are nurse practitioners who are specialists in therapies. There's marriage and family counselors. There's all different kinds of psychologists that are not as expensive as an MD, which is what a shrink is.
I know one of the problems or the issues is that I have seen is that where the patient is in total self-denial of the, that there is a problem and there is a disease that has to be addressed, even though they take care of themselves and do the proper stuff. They, if you want to look at, try to minimize the impact on their life. And I have seen it where it makes the caregiver or the significant other feel helpless of trying to really do the best that they can for the patient.
And what's your question?
And the thing is how to make the patient understand that, really that they're not alone, is that there is something that's impacting their life, and, that, there is a change that you have to address, even though, you want to, if you want to say, ignore it.
Well, sometimes people, it's not bad to ignore the disease as long as you do what's required. In other words, I don't want to talk about this. Yeah, but did you go to the doctor? Yes, I did. Are you taking your medicines? Yes, I am. Are you feeling a little bit better? Yes, I am. Okay. Because denial, we go back to those original slides where all behavior has a reason. And denial is a way for people not to have to deal with the emotional impact of this disease because they're not ready. Now, the main thing is if they are doing what they're supposed to do to take care of their body. That's okay. Let them do the denial for the period of time. When they get into trouble, if they get into trouble, that's when you need an intervention. That's when you need to come down hard on them. And you say, look, you didn't take care of yourself. You're getting sicker. I'm not tolerating this very well because I love you and I don't want you to die earlier than you're supposed to. So what can we do about this? Sometimes it takes an intervention from a psychologist. Sometimes it takes a family to sit down and say, stop this crap. You can't do this. We are going to lose you and we won't tolerate that. Intervention kind of like you do with somebody who's on drugs and alcohol.
Okay.
So it depends, and it depends on whether or not the person is taking care of themselves anyway. Right?
Okay, thank you.
Yeah. I remember a woman up in Evergreen who never came to a support group. Didn't want to see it, didn't want to hear about it, nothing. But she kept contact with one of our members. And every so often they would call each other and keep up with each other and everything. She was doing fine. She went to the doctor, she took her medicines. She died after 25 years, so she was doing pretty well. But she never confronted it otherwise.
Okay. Well, thank you.
Yeah. Okay. So what should you do together? Because after all, that's the whole point. You got to talk to each other. You got to share what helps. Sit down and make lists together. Check in with each other. How am I doing? Am I doing the stuff that makes you feel better? Use the methods you have used in your relationship before. So it's kind of like what Mike was saying before, that he and his wife had been through already a catastrophic disease, and now they have another catastrophic disease to deal with. And I'll bet you used some of the same things that you knew about from the last time to work on scleroderma for this time. So it's your turn.
Yes.
And help other members of the family learn what you learn. So it's a process. This is not a sprint with a goal at the end and it's finished. It's never finished. And if you look at it as a marathon and a process, it changes people's minds a little bit about how much they need to do and what they need to do. So it takes time. Teach the young members appropriate for their ages, and doctors and nurses can help. So if you have a pediatrician for your children, talk to the pediatrician about age-appropriate explanation about the disease and what mama is going through or papa is going through. As you can, continue to do what you love as a family. So camping is going to be a problem if the person has terrible Raynaud's, but maybe camping in the summertime and forget about skiing, or maybe skiing in a different way, staying a lot more in the lodge. Take a break from the disease. And one of our friends and I went to, she has the disease, and we went to a conference, and she said at the end of the second day, she said, if I hear the word scleroderma one more time, I am going to scream. So we took a walk for about an hour and it helped. So take a break from the disease. Adapt. That's a very operative word for chronic illness, is that you have to adapt to everything. And it takes a lot of energy and a lot of support. Pain will happen. Suffering is optional. I like that because it changes your mindset. Pain can happen, and there's always something that you can do about something. Dan says that all the time. In the 70s, somebody did a study on hugging. They came up with some very interesting things. Like if you hug somebody for 20 seconds, there is a surge in your endorphins. And they actually drew blood and they figured it out. And the endorphins make you feel good. So they figured out that if you're feeling okay, then 4 hugs a day will maintain that okayness. And if you don't feel okay, you need 8. But of course, there's no end to how many you can get because it's a mutual thing. So hug a lot.
So minimum of 4 hugs a day, every day for the loved ones and for each other. That's great.
For each other, yeah. Because you can't give a hug without getting one.
Correct.
Nice. And kids laugh 300 times a day and grown-ups only 15. So let's think about that. There's another patient who, when she's down and she has a down day, she just pops in a tape of the Three Stooges and just laughs her day away. And laughing also raises your endorphin level, so you feel better. Next. So here's a bunch of stuff that people can use that I looked up. There's all kinds of living well with a chronic illness information. And I'm sure there's more, but I didn't want to overwhelm people. And the next slide is my family.
Oh,
That's our grandsons.
Beautiful.
And there we are having food, because the Italian in our family, we always have food. And those are our 2 little grandsons in the tub. And this is everybody that celebrated our 50th wedding anniversary.
well, congratulations.
Oh, that was 3 years ago, honey.
Well,
So now we're up to, it's actually 4 years now.
50.
54.
Wow.
So Elaine,
So this is the family.
so I want to say thank you. I know earlier that you mentioned that you wanted to share something that if people wanted this presentation.
Oh,
Yeah.
yes. If people want this presentation, just email me. And that's why John has put up the first slide, because it has my email address. And I will send you this whole presentation for you to have yourself.
Well, I like to personally thank you, Elaine, for an excellent presentation. Your time spending with us today to be able to share with our patients and our caregivers, because, like you said, the caregivers and the family at times are overlooked, and the patients get the necessary support. But it's like you mentioned, it's not just us. It is, as you mentioned, is the total family that needs the support. So from that standpoint, I'll say thank you very much.
Well, you're very welcome. And it was kind of like a little support group for us today,
Yes.
wasn't it?
It always is for me, so.
Job.
Cool. Well, call me anytime. You know,
Okay.
Dan and I are available.
All right. Michael, I think Michael has a few closing comments, so we'll let Michael wrap this up for us.
All right, very good. Thank you all. Thank you so much, Elaine, for presenting today for the Scleroderma Foundation. I know this information has been beneficial for all of us, and thank you for helping to educate the Scleroderma community. Thank you also for all you are doing for the Scleroderma community. Staying educated about your disease or the diseases that affect your life or your loved ones can help and become a more effective healthcare advocate. If you have any questions about anything that has been presented on this webinar, it is best to bring them to your medical team, as they know your specific medical needs and can help you make the right decisions. Thank you again for viewing this webinar. Thank you, folks.
See you in Seattle.
Absolutely.